that one working too? Yeah, okay. Thank you, thanks Joel. So we're going to have a bit of a panel before we then get into the awards, and then what's happening after that? Lunch. Okay, so let's get the panel up here. So I'd like to invite into the company chairs, Joel, this Professor Joel Reedy, who you already know, Hester, Dr. Hester Wilson, fellow GP, addiction specialist and medical advisor to many of our programs, and PhD candidate at the moment, yep, and also conjoint senior lecturer at UNSW. Natalie Hanson, CEO of the Central and Eastern Sydney Primary Health Network. Really happy to have you on the panel, Natalie. And is Jenny with us? Jenny, please. Jenny Casperson. Jenny's the manager of the Primary Integrated and Community Health program. Yeah, whichever. I don't know. Can you see everybody sitting here? You can. They're very short. Yeah. If you're sitting behind Mark, you probably can't see anybody. But yeah, if you're okay, I'll. I think, oh, that's better. I think someone's got the Slido questions. Who's? Oh, you have, Joel. Okay. But I thought, firstly, I'd just like to ask the four of you, just from the presentations that we've had, what are the really important take-home messages for each of you?
I'll start. This is really hard. That's what I take away. But also that there's this really committed group of people that understand, you know, equity and access to care is really important. And so, you know, to take my hat off to you guys, really trying to work in this space and research really rigorously. And there's some real complexities, because that's what I took away.
Okay, thank you. Yeah. I'm not sure it is.
Pitch primary and integrated community health, but I work for the Agency for Clinical Innovation, which is the innovation project arm of New South Wales Health. So I was interested in the focus on shared care in the projects that we're doing, and as Hester said, it's really hard. But shared care is a focus, very much a focus, and I think highlights the importance of primary care in any projects that we're trying to achieve some really positive outcomes.
Ms. Jane?
From the primary health network perspective, I'd say all the presentations really reinforced to me how much we still need to keep working on sharing information better and finding technology solutions between the acute system and the primary care system, because really those shared care planning, e-shared care tools, if we were sharing the health record adequately, we wouldn't need all that. So I think we really need to keep pushing for that. I think the area of research in general practice is an interesting one. We're about to release our research strategy as a PHN, and I think we need to get better at identifying GPs that are interested in research and looking at ways that we can support them to do that, and building up the skills in research as well, offering opportunities, and that's where I think we can work in partnership with the universities to do that.
Thank you. Joel?
Yeah, I guess just reflecting on the presentations and the comments, I just feel like I found my comrades in terms of, because a couple months ago, I shared in a different forum the fact that I conducted a survey and we actually got a response rate of less than 1%. That was in general practice survey, and I feel that some of the presentations today makes me feel very sympathetic to the issues that you are facing. And I think what others were mentioning is the difficulty of conducting research in general practice. And I think that's something that I suppose we can discuss further in this forum, but how can we engage?
So why don't we explore that just a little bit, because it is a really important topic and it's really important for the work of the centre. And of course, Mark addressed this beautifully in his oration, the contemporary challenges of primary care research, and you're all involved in primary care research. What are you finding as being the biggest challenges, but also what are the solutions? Look like you're poised.
Look, I was going to pick up on the point about how you engage with GPs, because that's something that we as PHNs are always trying to do. And I would say there's maybe 30 or 40% of GPs that are really engaged and that we get our message, and it's to the other ones that it's very challenging to do. But I think there has been increasingly some new initiatives, you know, such as the recent government investment in the Strengthening Medicare GP grants, which is all around building digital health capacity, infection prevention, control, etc. And that is getting a way for us to engage with practices that might not typically engage with the PHN and really bringing them into the fold about what's happening. But I think the challenge is also the volume of information, and people are just so busy. How do you get that message out to people? It's challenging, and we promote research opportunities through our weekly e-newsletter, but I don't think you're getting to the vast bulk of them.
I'm going to come back and quiz you about PHNs. Jenny?
Hester and I were chatting at morning tea about this. I started working at the organisation that I'm currently working at about nearly 10 years ago. One of the first messages was, how do we better engage GPs? And the question 10 years later is, how do we better engage GPs? Because, and part of the issue is the funding model, in that if we want to talk to GPs or get them involved in our working groups or any of our projects, they need to be paid, because they're otherwise taking them out of their practice hours when they're being remunerated. Not particularly well, I might add, often, but they can't afford to take that time out from their clinical day and their clinical workload. So we either engage them in the goodness of, the goodness of their heart out of hours, which again is a bit tricky for bureaucrats, because then you've got to get the bureaucrats out of hours, or you pay them. And that's been the model that we've had to employ, is that we pay the GPs for our general practice advisory group, which meets every 2 months, but we remunerate them. And that is a major challenge for recruiting GPs. They're busy, they're stressed, and they just don't have time. And the other alternative is to find a GP who is associated with the PHN, where they're remunerated by the PHN somehow. But it's not an ideal solution, and engaging GPs is challenging.
Esther, what's the solutions?
I went to medical school before we did all this stuff, like primary care research. You have no idea what that is. And then I kind of got interested, and then I was asked by some researchers to put my name to a research project, and then I never heard anything else, and I didn't know if the grant had happened, and it just kind of felt like I was a ticker box. And then I decided to do some research myself, and so I'm very fortunate to have Mark as my supervisor, and I know he's retiring and Ben's taking over, but he'll still be involved, I hope, until the bitter end, which I hope will be next year. But I've self-funded that. I've done that in my own time, just because I'm really passionate about the area. And when I think about it, I think about how can we build a kind of a culture in general practice that goes back to your training as a medical student. You know, that research is part of that, as part of your GP training. Research is part of that, and it's integrated into that, and it's paid. You know, we do need to remunerate and because then it's about being valued, and so that it just needs to be more deeply embedded, because it never has been. But also really seek to speak to our values as GPs. Maybe there are some GPs where this isn't the value, but I know for me as a GP and for my GP colleagues, that it's about good healthcare and good outcomes for our patients and doing worthwhile work. And so, you know, I guess it's about embedding it as core to the business of general practice and primary care. And I would, of course, primary care is much broader than that. So it's also embedding it in dietitians and dentists and, you know, for all those people working in primary care. But it's also around making sure that you're able to speak to the values and really allow people to have real engagement in it rather than being.
Yeah, thanks very much. I was just reflecting on my survey response rate, and I was then thinking about the very first project I did. The very first project I did when I was an academic registrar, and my supervisor was Nick Swar and Sanjos, and so we were based at GP unit in Fairfield. And my first survey was actually surveying GPs about their involvement in palliative care. And the response rate I got there was 60%. And we got 260 responses. So it wasn't like we approached 10 and got 6 back. It was 260 people. And coming to think about it, I think the real difference there was a real personal connection, which I feel happened there. And the reason being, and it was a slightly different world, although it was not too long ago. The ethics and other things were a bit different then. So I actually contacted everyone who didn't return the survey, personally called them. And then when you mentioned the doctor word, the receptionist often gets you through to the GP. So you actually speak to the GP saying, I'm a registrar, I'm really trying to do this project, can you please answer the survey? And they're like, oh, fine, I'll help you. And then we put in some coffee bags into the envelope as well, so that they can have a coffee while they complete the survey. So I think that personal connection maybe is something that could really be useful. And I mean, I think when coming to think about the strategy moving forward, if there's a way for us to foster a network, and I think what others mentioned is the whole Mark and others, or Andrew and others, going out to the practices and meeting with people. I think that's probably the way to go, although that's going to require money.
Now, someone called Anonymous has sent in a whole lot of questions on the Slido. What's that? But the most recent one from Anonymous was just expanding a little bit, because we're talking about GPs, but expanding a little bit about the role of professions other than GPs involved in primary health care and engaging them in research. And I think this is really important. We've just seen the Medical Research Future Fund has announced $100 million of research funding for primary care, which is more funding than we've ever had announced. Is that right, Andrew? Can't remember ever seeing that amount coming forward. Half of it is for long COVID, but it's the primary care management of long COVID, recognising that long COVID is managed in the community. And the other half is around the Strengthening Medicare Task Force recommendations about multidisciplinary care, patient registration or enrolment, and the incorporation of new technologies into care. But it's more than general practice. It's all of the healthcare workers who are involved. So, you know, if we're going to be involved in this research, we're going to have to all be working together, rather than, you know, here's a group of GP researchers, here's a group of community nurse researchers, here's a group of dietitians. So just tell us, you know, what your reflections are and how to get us all working together, all the professions working together in research. I guess let's start with the PHNs again, Natalie, because you're there. You're not just there for GPs. You're there for all of primary healthcare in the community, aren't you?
Yeah. So, well, an example where we have got allied health and general practice to work together in research has been around practice viability. So this was as a result of COVID. We noticed that practices, both allied health and general practices, were complaining that they were less viable. So we did contribute some funding for a research study, which and that included led by co-led kind of by allied health and general practice, and it was quite good in that way to get them both involved on something that's of a common interest to them. Another thing that we have happening in our PHN is a clinical leaders network where you invite both allied health and GPs together so that they can share conversations, meet each other. Same thing happens on our clinical councils. So I guess it's putting opportunities together where people can talk about the issues that matter to them and realise where there might be opportunities to collaborate. We did that recently as well with our strategy workshop where we had 3 issues that people could work together with other stakeholders in the region. I think it's giving people that opportunity to meet each other and giving them something a bit tangible to work on as well.
Multidisciplinary care is often trotted out as an ideal scenario, and I do believe it is, but it's hard. You know, it's not a simple solution. It's not an easy fix. I've recently been doing some work on menopause, and the New South Wales government is funding over the next few years setting up new menopause services. And menopause is a classic example of the need for shared care and a multidisciplinary team because there are so many aspects to menopause. But it's really challenging, and often it's relational coordination that's really important. That seems to be the solution to setting up, and it will be an answer for setting up those shared care clinics when they eventually are set up.
I've just got to come back to the whole funding, you know, so the idea that you can have these wonderful collaborative multidisciplinary teams, brilliant. I'd love that as a GP. But how are we paid? You know, and how is the dietitian paid? How is the dentist paid? How is the community nurse paid? We just, you know, I compare it to the multidisciplinary team that I work with in Southeast Sydney LHD, where we do work incredibly well together from different craft groups. We're all employed by the same organisation, so there's kind of clear goals and we're paid to do that. And there's just such fragmentation in primary care. It's really tricky. Like your future, what's it called? Your leaders, clinical leaders, brilliant idea, but it's on the weekend, isn't it? Or evenings, and life's busy and we're not paid and yeah, I'm sorry, but it does come down to like those systems and those shared goals, you know, absolutely, but also the mechanisms that people have for the time and their expertise.
Anonymous has actually responded again, and he or she, they have said it seems to be more acceptable to pay GPs than other primary healthcare research collaborators. What do you think about that, Hester?
I don't think anybody wants to pay any of us, basically, you know. So, and absolutely, we do need to be paid for our time and expertise. And I'm hearing, you know, so as Catherine was saying, you're given a modest amount of money because the funding body wanted you to recreate Ben-Hur on $2, you know. So it's unrealistic expectations, and I don't know. Somehow we're supposed to do it for the love of it. You know, yeah, that's great, but we do need to be paid, and research projects need to be resourced and funded appropriately, because otherwise you have this frustration, you know.
Yeah, I think I wonder about the private-public divide, and I get a lot of the questions or the issues we're experiencing may be related to health service versus private health service, and how the feds and the states are funding the system is that primary care seems to be a private system, whereas the public system seems to be New South Wales or state government funded. So I wondered about that, and I think what Hester and others are talking about in terms of other discipline groups, especially primary healthcare, they're also private as well. And so engaging with them. I also wonder about the importance of research or trials network. So when I'm part of one research group or trials network, and it works really well when you get a bunch of people together who are really interested in research from different disciplines, and it actually works really well. But I always wondered, you know, for primary healthcare trials group, there isn't one, and I don't think there is. So why is that the case? And I wondered about bringing people from all the different institutions together, different multidisciplinary groups, fund them well, and then you can generate ideas, you publish papers together, go for grants together, build up your network, and then.
Do you have other disciplines apart from general practice in your trials network?
So the one that I'm referring to is not hosted by a different university, so I won't mention the name, but it's general practice, but also it's got subspecialty specialists from medical and nursing. It's got allied health. Consumers are heavily represented there as well.
One of the easy tasks that I was given as Deputy Chief Medical Officer by then Minister Greg Hunt, he said, Michael, I want you to bring together all the primary healthcare peaks from across Australia for a meeting at least once a week, preferably 2 or 3 times a week, and on the COVID response, on the primary care response. And I went out and I managed to, at first pass, find 50 different representative organisations for community nursing, for all the allied health professionals, the dentists, the pharmacists, all the medical groups, the deans of nursing and medicine and allied health, and flying doctor service, and all sorts of different groups. And we did bring them together. And we brought them together 2 or 3 times a week via Zoom. You know, you're all familiar with Zoom. Everybody is the same height on Zoom. Have you noticed that? There are no tall people or short people on Zoom. And we met up to 2 or 3 times a week for nearly 3 years. And what struck me was, firstly, a lot of these people didn't know each other, even though they were the leaders of their different groups. And secondly, how well they worked together. It was a highly functional group. Any competition between professions was left outside the room because we were dealing with COVID and there wasn't any room for that. We were dealing with a life-threatening emergency, and it really opened my eyes to the fact that we should be doing so much more working together. And I wonder, again, I'm going to pick on you, Natalie, with the PHNs. You know, what was your experience with COVID, and do you think that the role of the PHNs has changed because of what we experienced over the last 3.5 years?
You're right that COVID did make people collaborate. It did facilitate collaboration a lot more than what happened previously. So we found our relationships with the local health districts, with community services improved, and I think that is still continuing. Although people, I think at our recent strategy workshop, were saying we've lost some of that urgency, you know, around community services being focused on that one issue, and we're going back to our old ways. So we need to kind of record these lessons and try and find ways to kind of keep doing this collaboration. I think it's definitely easier when you've got one thing that you're working towards, and it's harder when now we're back to having to resolve a whole big broad range of health issues and problems. And yeah, I do think we probably need to agree on what the fundamental things we want to change are, and do a bit of a step-by-step process. I am encouraged, though, that there is such a willingness to relook at health reform, and I think the role of PHNs probably solidified through COVID. We were able to demonstrate that we could be agile and respond well. I think one of our advantages is that at a regional level we can bring people together, and for some reason they don't feel too threatened by us. I think because we're small organisations, we're not going to take over their work. And I do think that is one good thing that we can do and we need to build on. That's my initial thoughts.
Thank you. How did things change for you and your organisation, Jenny, as a result of COVID?
Well, prior to COVID had been banging on about telehealth and virtual care for years, and suddenly, zoom, everyone was on the, trying to get us, and it was fabulous. I mean, it was fabulous for us because suddenly these things that we'd been, bludgeoning away at, suddenly saw the light of day, and it was fantastic in that respect. I mean, there were so many dreadful things about COVID, but that was one huge positive. And the other thing you touched on was the incredibly goodwill and the cooperation and the keenness to collaborate. It was really gratifying. Suddenly there were these people who'd never got together, never met each other before, and they were suddenly just keen as beans to work together. And there was a sort of a really exciting camaraderie that came out of those early days of COVID. And so that was really heartening, I think. I mean, our organisation was very much involved with, the setting up the clinics and doing other stuff. So we pivoted to not, away from our business as usual projects and sort of down tools and set about doing the response for New South Wales Health. But there were some really positive elements of COVID, and I think that's, and I was reflecting on the presentations also, the use of technology. 10 years ago, we wouldn't have been talking about that uptake of technology, and I think we can relate that to the advent of COVID, I think.
Esther, what did you notice in your work?
I think one of the reasons that maybe people got more involved was that we didn't really have much else to do because we were locked down. So it was either day drink or get involved in something. Being facetious. But I do think that, there have been some really great outcomes, and the understanding that telehealth is safe, is appropriate, can actually support good health is brilliant. And I have a very part-time role out at Murrumbidgee with the Drug and Alcohol Service out there, and we have telehealth from St Vincent's, and so we have the addiction specialists virtualing in to see our consumers with their clinician in around the Murrumbidgee area. So Murrumbidgee is huge. It's got about 250,000 people, but it's a huge area. And that is, I honestly don't know how a drug and alcohol service functioned before we had that service. It's just been absolutely brilliant, and it kind of convinced us that it was safe and it was effective. Telephone, maybe not so much, and certainly that's one of the issues I was interested with your studies was the group of people that I work with don't have data, don't have phones, don't have computers, or you spend the whole of your virtual care session going, okay, so you see that sign down the bottom that looks like a yellow E, click on that, because they don't, it is tricky. And so that's one of the things is that with the most vulnerable, those virtual aspects may not be as helpful. And the last thing I think about technological solutions is that they're just that, they're technological solutions, and unless you've got engaged, educated, keen, workforce that have capacity, you can have all the technological solutions in the world, but they're not actually going to work.
Joel, what did you learn?
Yeah, I guess we became very good at Zoom and Teams. So I guess different ways of working, definitely. And but I think one of the key things, I remember first when lockdowns and other things started, we couldn't see patients face to face, and trying to set up this video thing for patients, and then realizing that, okay, I'm spending 30 minutes doing tech support at the moment, trying to make this work. And that's when you start to begin to realize it's really about interpersonal connection. Technology is there to support, but technology is not the focus here. And key component of this is really just effective communication and just asking patients how they're feeling. Can you tell me more? And I think the more time you spend with patients and the more care you provide in terms of that can overcome a lot of barriers. So I think that's something that we learned. And I think another thing which many general practices also, I think, realized from COVID is there's a lot that GPs can do. And I think your own presentation on Sunday, which illustrated the the fact that even when it comes down to COVID-19 vaccinations, the primary care were responsible for most of that. And I think it's incredible what primary care can accomplish when we've got the willpower and then a little bit of support and funding.
So we are seeing continuing reforms of primary healthcare in Australia. Just this month, we had the introduction of voluntary patient enrolment, with people being able to enrol with the general practice of their choice, and with funding which supports more comprehensive care, and it may be a way of getting some more of that multidisciplinary care funded through general practices. Tomorrow we have the triple bulk billing incentive introduced to try and encourage GPs in particular to bulk bill people who, as we saw right at the start of the day, who are avoiding going to a GP because of cost. And we have continuing funding for telehealth and hopefully for more video calls. I think it's a real opportunity for this centre as all these reforms are taking place. And just wonder, we've got some people here who may be planning to do a PhD. If you are planning to do a PhD, what's the topic that you'd focus on with the reforms that we're currently seeing at the moment in primary healthcare around Australia? You can go first this time, Joel.
I was expecting
Kick on your toes.
No, it's a very. I think I'm particularly looking at the tripling of bulk billing incentive. I think that's a really interesting thing to look at, and I also wonder about, because I think the real benefit for that is particularly in people living in rural areas. That tripling really benefits the people who are sort of getting $11 or $12 at the moment. I think at the moment in rural areas, that suddenly becomes almost close to $40 with tripling bulk billing incentive. So I think that's really good. But I also wondered about people living in sort of Sydney and who might be experiencing homelessness. So those people who are equally subject to the similar sort of situation of inadequate access. So what about those patients, and what's going to be the impact on those patients? So I wonder whether there's some research that can.
That's great. Yeah, Mark, you shouldn't have retired. There's going to be so much to do. Who'd like to go next? Who's got a good research topic for the potential PhDs in the room? What would you like to see done in response? Yeah, go ahead.
I don't know how I would frame the topic, but I do think one of the major challenges for primary care is workforce, because we know that medical graduates are not considering general practice as a career. We know even with the allied health workforce associated with primary care, it's very difficult to recruit staff. Some investigation into improving workforce, I think, would be a really important component, because if we don't have enough GPs, we don't have a primary care workforce, how are people going to get access? How are the really vulnerable populations going to get access? It's going to be even more difficult for coal communities and vulnerable populations to get access to good primary care. That would be my focus.
That's great. Thanks, Jenny.
I'd like to see some research done on what is a sustainable model of multidisciplinary team care now that there's more incentives to do this. Look at what people are trialling. What's the experience, and how do you make it work? I think there'd be some good research in that.
Are you going to change your topic?
No, I was just thinking, geez, how do I think of a research? Research questions are really hard. But when I'm thinking about me as a GP, what I love about general practice is I love that longitudinal care of individuals and families and my community. I love working with people over time who have disadvantage, complex health and welfare and life issues to assist them to improve that. And so and as a doctor, it's the curly kind of complex stuff that I'm interested in. So I love working as part of teams where the dietitian can do the nutrition stuff really expertly, the dentist can do the dental stuff really expertly, the nurse can do the nurse stuff, I can do my GP stuff, and we work in a multidisciplinary team with shared goals, but working and using these changes, the possibility of my bulk billing item changes to really actually address and make really substantive changes to people's life experiences and health outcomes. I don't know what the research question is.
Great. Okay. Now, Anonymous, you've stopped sending in questions, which is making my job much harder. So whoever you are, please feel free. Okay, Ian, it's your day.
This wasn't right. Now, by the time I've been reading up there, information. I can tell you hearing wants to do someone that means and
Thank you, Ian. In fact, Anonymous has put the same question, which makes me wonder if Anonymous is actually ChatGPT. So maybe it's not he, she, or they, it's it. What is the role of artificial intelligence in moving forward and improving the quality and access to primary health care? It's so clever. It is. It's so clever. No. So who'd like to have a go at this one? Let's talk a little bit about AI and quality and access in primary healthcare. Does it have a role in what we're doing? I got really excited at the start of the year when I first heard of ChatGPT. I thought it was something for GPs, especially for us. And I was really disappointed when I found out what it actually was. And I don't know if any of you have tried using it, but don't use it to write your papers. You'll end up plagiarising because it's the biggest plagiarism source on the planet at the moment. But does anyone have a go at this one? Jenny, you're itching.
I'm just giggling about it because I last week for the first time actually downloaded the app and sort of engaged with ChatGPT because I was curious about it. And it talks to you like a person. Have you used it? It's like a
yeah, we chat every night. It's great.
Actually, I read someone on Twitter who chats to ChatGPT every night. That was a bit sad, Michael.
Oh, okay. Well, the doc doesn't answer back. So,
yeah. Look, I'm rapidly getting to the age of considering myself a complete dinosaur, but I think AI is really exciting in the healthcare space, but with massive reservations about that because I think it's like the Wild West. I don't think there are the right. I don't think there's been enough research to keep up with the advances that are happening in AI, and that makes me, as a human being, quite nervous. But I do think that there is huge potential for AI in healthcare and possibly, hopefully, making life easier for stressed healthcare professionals.
Natalie?
Look, my thought is maybe it can be used in the assisting the consumer around it, maybe a digital assistant or there's so much information when you're looking online about various health conditions and what you're meant to do. Is there some way that there could be like a little AI chatbot? In fact, I think I might have even seen it in one PHN website where they kind of help you to find the information that you need, and as long as it's reliable information, etc., that might be a bit of an answer to some of the health literacy challenges that we've got.
I think one of the models that I've seen overseas is the digital double, where you can take your patient and using AI you can create them and see what happens when you add new medications or do different interventions. And so instead of sort of trialing it on the patient in front of you, you can do it on the digital double. Yep, they survived. Okay, maybe we can do that with you.
I think that's totally cool. I'm not sure quite how it works. Yeah, I've used ChatGPT once, and that was to write my dad a song for his 90th birthday. And at the party, I went around to everybody and said, what are the words you think of when you think of my dad? And they said all these things. And I put it to the tune of Whiskey in the Jarro, and we all sang it. It was brilliant, but I've not used it for anything else. I reckon it's good for that stuff. But what is AI? I don't know. I don't even know if it's intelligence. Isn't it just a big algorithm that pulls up stuff and it actually has no mind? I think we get a bit bamboozled by it. But I guess the reservation that I have is just beware who owns it. Beware who controls it and what data is then fed into it. Because it may not, like, I don't know, if you use those chatbots on like Telstra or whatever, they're really annoying. I want a human. I just wanted to speak to a human. Anyway.
So like when I think about guidelines AI, and obviously I'm just mindful of there are many guidelines for many diseases out there, and as the additions increase, they increase in thickness. And I think it's sort of getting to a point where obviously it's very difficult for individual practitioner to read through. And it sort of becomes tricky because how do we use these guidelines? Because is there something that you sit down and then you say, okay, I'm going to study guidelines, and then you memorize them? Is that what you do? Or is it meant to be used when the patient's there in front of you? Go to page 170 and then look through it. So I think it becomes quite difficult, and I wonder whether AI has got a real place in being able to, you can ask it a specific question from a particular guideline, and whether you can actually pick that out, and then give you the response. And possibly, what if you could even provide a little bit of patient details to the AI, and then you can tailor make according to what's in the guideline back to you. So something like that, I can imagine it could work, and that's where it's enhancing clinicians rather than replacing clinicians. And so I wonder whether that will improve it.
I mean, arguably, we've been using artificial intelligence in general practice for 30 years since the medical director prescribing software was introduced, and was providing clinical computerized decision support. We had a list of the patient's medications, their conditions, their allergies. You prescribe a new medication, and it would alert you if there was a problem with that medication. So it's not new. It's just the technology has advanced. So I think you've raised a really important issue, Joel, which is if you did put patient details in there, whoa, what does that do for privacy and confidentiality, which needs to be high? And Anonymous, ChatGPT, has asked, could you comment on the equity implications of AI given the equity focus of this centre? So what do you think about the equity side? Let's go with you again, Joel.
Yeah, I guess if it's applied at the patient level, there could be significant consideration, I think, especially if a patient don't have access to IT infrastructure or they're not particularly literate when it comes to health technologies, then I think there can be a significant issue. I guess if the AI is helping, if it is running on the background or helping to optimize, say, even in terms of like patient flow, optimizing that, or being able to predict no-shows because every clinical service has no-shows. So what if it's able to optimize or work out, okay, we think that there's going to be 3% no-show today, and then you can then, I shudder to mention Qantas, but to do what airlines often do, which is overbook, but do it really well, that kind of thing. So I think there can be, equity can be improved as well, as long as I think we're aware of the equity issues.
The other area is that none of my patients just have one condition, they have multi-morbidity. So that's the issue we always have with guidelines, is they are focused on a particular area and how does that apply to my patients in the real world. So if AI can help with that, around that complexity of decision making, that would be totally brilliant.
Well, the other thing that struck me was the use of translators for call community. I mean, surely AI could assist with language, and that would be a huge improvement in terms of translators. Yeah.
Do you think, Natalie?
I don't know that I've got a huge anything major to add. I think you've covered all the points. Probably, I do think it is an issue for equity, as is all technology, which we really. But I was encouraged by, I think, that description of the trialling at the Haymarket Centre, the virtual hubs, and I think that is happening a bit all over the place. It also happens in libraries, etc. So that is a way to kind of address some of those issues. But yeah, it is going to be, of course, taken up by people that are more educated and don't face all the barriers that are more vulnerable do.
Mark, can I ask you, what do you think? Do you think AI has that potential to actually benefit our equity aims?
Yeah, I'm not so sure about the translation because I know that Google Translate's actually used quite a bit by clinicians in dealing with people who don't speak English, and the general results are pretty poor. It's that's not really full AI, I know, but I just think we need that. One of the lessons out of that is we need to be aware of the limitations of the technology, and because again, it'll tend to get applied perhaps most adversely to low socioeconomic groups, people who are from culturally and racially diverse backgrounds, Aboriginal people and so on, just simply because the services that are working with them will be under more pressure and dealing with more problems. So I think we need to keep that in mind when we think about the technology. But no, I think it's got potential, but again, like all these things, it's a tool, and we need to. It's more how it actually gets used and in what context.
Thank you. So I think we're about time to draw things to a close. So just like to say huge thanks to Anonymous for helping with this session, whoever you were or whatever you were. But big thanks to Jenny and to Natalie and to Hester and Joel. Please join me in thanking them all. And over to Fiona.
So thank you, everyone. Thank you to our presenters and our panelists, and we'll be eager to see how the projects described continue to develop. And thank you for the audience, particularly Anonymous. Thank you for the robust discussion. Keeping on the sentiment of gratitude and appreciation, every year the Centre give out awards to recognise and celebrate people and organisations who collaborate with us, support our work, and generously share their advice, wisdom, and guidance. Because we all know we can't do it alone. It takes a village. We would like to thank our long-standing collaborators and supporters, and some of who have been with us since the beginning. So helping me with the awards is Professor Michael Kent. Thank you, Michael. You ready? Here they are. You're doing the handing out. So first up, we've got the individual award. So the recipient of this award inspires and empowers those around them to undertake vital, sometimes daring research collaborations, programs and agendas to support impactful research with real-world influence. Their persistence and determination in advocating for health equity is to be celebrated. So congratulations, Maria Beer. Maria is the Manager of Business and Collaboration within the Population Health team at Southwest Sydney. LHD. Today she's actually somewhere in the Himalayas doing good things. So Mandy Williams, Director of Population Health, will receive the award on Maria's behalf. So as they do this, yeah. Great. Now on to our next award category, the Centre's Organisational Partnership Award. So the recipient of this award has been recognised for their unwavering commitment to promoting and strengthening health equity and their strong partnership and collaboration with the Centre. The award goes to the Muslim Women's Association. So today, unfortunately, Fida Abdu, the Communications and Community Relations Manager for the organisation, was planned to be here today, but as you can imagine at the moment, they're actually just really, really busy working directly with the communities they support. So she can't make it here today, so we're going to send it out to them. So the partnership between CPHCE and the Muslim Women's Association has been really founded on a shared vision of health equity and a deep understanding of the importance of culturally responsive care and community engagement and empowerment. Through a number of joint initiatives and programs, the Centre and the Association have worked together to create a more inclusive and equitable communities. And they've collaborated us on a number of projects over the years, and we look forward to working with them in the future. So our next Our next award category is the Consumer Award, and the recipient of this award is recognised for their consumer advocacy work that helps shape healthcare policy and practice. The Consumer Award this year goes to Christine Walker. So Christine is a consumer advocate and CEO of the Chronic Illness Alliance, the peak body representing over 50 consumer and advocacy organisations for people living with chronic illness. Christine has been a member of the CPHCE Advisory Committee for 15 years. So she's been a constant source of guidance and advice to us. She's also been a research collaborator on numerous projects, particularly concerned with the needs of people with experiencing chronic illness, and particularly in relation to health systems. So she's a leader in advocacy and research. Congratulations. Our next award is the General Practice Award. The recipient of this award consistently works to strive for equitable outcomes for patients and consumers in the community and has undertaken impactful programs of work and research to enhance positive patient outcomes. The award this year goes to the Malibu Medical Centre for their work on the shared clozapam program. Accepting the award on behalf of the Medical Centre is Joanna Ashby. She's the clozapam and shared care coordinator at Neuro Clinic. So the Malibu Medical Centre has really embraced the shared care clozapam management of people with a lived experience of severe mental illness. And this has come at a time when the clinic has found it really difficult to find GPs to take on the role, given all those pressures that we've been talking about. You know, and at a time that, you know, researchers have been really struggling to engage with GPs. So we really do appreciate their partnership and work together. So one final award. And then we get to the next and final award category for today's forum is the Centre's Career Achievement Award. This is an award that we don't give out every year. So the recipient of this award is recognised for their equity-focused work in prevention and management of chronic conditions with a focus on primary health care and equity. Their work has had a significant impact on the health system and many people who work with it and within it. Passionate advocate for the right of everyone to have access to good quality care. Their research has been instrumental in shaping policies and programs that aim to reduce health inequities and improve outcomes for all. My great pleasure to award this year's Career Achievement Award to Mark. As you know, Mark recently retired from his position. He has officially retired, but he is still leading implementation trials of community health workers and also web-based interactive shared care plans for cancer survivors and patients with severe mental health illness. So I think he might be doing a Liz Harris. He's retired, but he's still with us. And Mark really embodies the Centre's mission of creating better, fairer health and healthcare in the community. So we thank you for your legacy, Mark. Congratulations. So now I'm going to hand over to Margot.
I've been given the job to close today. So I've been told that the video is working now. So we'll just do the video first and then I'll do my closing. So, and this is just, we think of
Equity is a trailblazer in primary healthcare and health equity related research, evaluation and development. Our commitment to designing local, place-based interventions that impact policy and practice, support and strengthen health equity and improve community health and well-being.
a focus of the Centre is around translation of research into policy and practice. One of the ways of doing that is to be really embedded with health service providers, and that's what we like to do in the Centre.
The nature of our relationship with the CPHCE is incredibly positive. We share very similar values and we have very similar interests.
A strong partnership is based on those sort of relationships between people at the end of the day, and that produces the great work that we're doing together. The translation of the research is just fantastic, and we're translating that and using that research every day in the work that we're doing.
The opportunity that the relationship with CPHCE and Chetra brings is also for staff within the district to participate in courses that are offered within the academic environment. We've had pieces of work that have been developed here in southwestern Sydney that have gone on to be implemented across the world.
This work is brought to life through collaborative efforts. Our partners include local health districts, primary health networks, government agencies and community organisations.
What excites me about our work is that we tend to do research that's aimed at making a difference. And often it begins with a conversation about some kind of problem or some kind of issue. And then a lot of our role is trying to unpack that and then think about what we can do about it. CPHCE have really spearheaded infrastructure within our organisation to allow us to have the capacity and the workforce to address issues of health equity.
Health equity and access to good quality, appropriate primary health care is a social justice issue that cuts across everything we do. Our team passionately drives high-quality research embedded within local and international partners, dealing with complex issues like climate change, urban planning, systems change, and advocating for equitable policy.
So while I'm working with refugees, I'm currently addressing a lot of assumptions that I've had, but I've been here long enough where I know that the people around me can support me.
Join us at the Centre for Primary Healthcare and Equity, a dynamic community where research transforms lives and fosters a healthier, more equitable future. Together, we can make a real impact on the world.
So thanks everyone for coming. It's so nice to be in person today, and we do have people online joining us via Teams, but it's just nice, you know, getting together, the conversations, and the panel discussion was really nice just to hear the challenges and the thoughts, and being in the room together has been really nice. Thanks to Mark for his oration, sharing his journey, as well as highlighting the importance of aspects of providing quality primary health care in an equitable way, and also for Ian for providing his reflections. Thanks to Catherine, Jane and Kathy for sharing information about the studies that they're working through, and sharing the challenges as well as the achievements, and you know, we're all trying to work together. We know it's difficult work. It doesn't mean that we don't do it. We just keep trying to find solutions for that. Thanks for Joel and Michael for chairing the sessions, and also for the panel for the great insights. Congratulations to all our recipients of our awards. This is our way of showing our appreciation for the work that happens, and a lot of our work wouldn't happen without the collaborations that we have. And finally, to Janelle and Sarah, who do all the hard work behind the scenes, making things like this happen. We have a little WhatsApp group that happens behind, and there's little messages going on at all times. So without those people doing all of that work, it just wouldn't happen the way today. So finally, join us all for lunch, and we look forward to seeing you at our next forum next year with our new executive director. All right.